Okay, so we have started recording. So welcome here, Dr. Brian A. Stone. He is a urologist and general surgeon from Birmingham, Alabama, and he is the owner and founder, chief of everything for Jasper Urology Associates, and also for Clinical Diversity Solutions. So I'm gonna go over his bio just a little bit here, but I can put the bio in the chat so you can fully view it, or I'm gonna take you to his website so you can view his full bio here, but it's just a little bit here. It's very detailed and excellent background. So Dr. Brian Stone, again, is a native of Birmingham, Alabama. He's a product of the Birmingham City School System and academic enrichment program of the 60s. He graduated from John Carroll Catholic High School in 1977 on a 4-year academic AFROTC scholarship as an Air Force scholarship to Rutgers University. He was accepted into Morehouse School of Medicine, completing his basic sciences there, and then graduating from the University of Alabama of Medicine, Birmingham in 1985, and completed his residency training in general surgery and urology at the Montefiore Medical Center and the Albert Einstein College of Medicine in the Bronx, New York. Completed his research fellowship in erectile dysfunction and a clinical fellowship in neurourology at the Weiler campus at the Albert Einstein College of Medicine. He served on scientific advisory boards for Pfizer, Bayer, Mentor Collapse, and American Medical System. And again, that's not a complete list there. He served on the International Prostate Committee with the United Nations at the Paris meeting in 2000. He has served on the scholarship committee at the Congressional Black Caucus, is an active member of the R. Frank Jones Urological Society, and has previously served as the national president of the organization, which is an affiliate of the National Medical Association. He's even worked with cardiothoracic surgeon Dr. Oz, who also allowed students to shadow him, and he was a surgeon for the New York Police Department from 2000 to 2019, turning in his shield last year. He is committed to the mission of bringing more Black and Brown kids to STEM and medicine, and he is a frequent guest on Fox 6 News and 98.7 KISS FM in Birmingham, Alabama. So welcome, Dr. Brian Stone. Thank you so much
for coming. Thank you. Thank you for the welcome.
Yes.
Thank you. So today we're going to talk about prostate cancer with a unique perspective from how it affects African-American men. Prostate cancer is very personal to me. I've had 4 family members who have had prostate cancer. This significantly increases my risk, as it does for anybody with a family history of prostate cancer. Plus, I'm an African-American male. Today, we're going to discuss the prostate, what it is, where it's located. We're going to try to get a basic understanding of prostate cancer, the risk, the symptoms, how common it is, what tests can be performed to determine if you're at risk, how the diagnosis is determined, what questions you should ask your doctor should you be diagnosed with prostate cancer, and understanding your treatment options. The prostate gland is typically about the size of a key lime. It's located beneath the bladder, and the urethra that carries the urine out of the bladder passes through the center of the prostate. As we age as a man, usually after the age of 30, the prostate gradually increases in size and can over time impact the flow of urine out of the bladder, causing symptoms. The prostate's function is to create the fluid that is found in semen. It does not make the sperm cells. The sperm cells are made by the testicles, but the fluid that sperm live in is produced by the prostate. You can live without your prostate. You may wonder why it is that urologists and other physicians put a finger in your rectum to check the prostate. And that is because the prostate is not in your rectum, but the posterior surface of the prostate is next to the rectum, and you can feel the posterior surface. This is where 90% of the tumors that occur in the prostate can grow and may be detected as a bump or nodule. Cancers are basically cells that have grown out of control and can spread beyond the organ that they start in. Prostate cancer is the most commonly diagnosed non-skin cancer in the United States. We expect there will be 288,000 new cases of prostate cancer diagnosed this year, along with almost 35,000 deaths, disproportionately affecting African-American men or men of African descent. Prostate cancer in general can impact 1 out of 6 men in their lifetime. Today, fortunately, 85% of the cancers, when they are detected, are found early enough that they can be cured. But this does rely on a man being responsible and having himself checked regularly. In the past, most people believed that prostate cancer was a disease of old men, but that is not true. We diagnosed many men in their 40s with prostate cancer. The development of the PSA blood test, which stands for prostate-specific antigen, has allowed us to detect cancers much earlier. Your risk is determined by race. So if you are of African descent, your risk is higher, or if you've had a family history of prostate cancer. Black men have a substantially higher risk of prostate cancer than white men, at a rate of almost twice that of white men. And our death rate is over 2 times greater than white men. For this reason, personal responsibility is required, meaning that you need to understand what the PSA blood test is, make sure you go to your doctor, and make sure you know what tests are being performed on you. We recommend starting at the age of 40. A lot of people think that when they go to the doctor, everything is just done, but I think there's a certain level of personal responsibility required so that you make sure that the proper testing is performed and the PSA blood test is performed. And when the results are available, you should know your PSA level just like you know your blood pressure. Prostate cancer is a silent killer, meaning that typically there are no symptoms. Let me repeat. There are usually absolutely no symptoms in the earliest stages of prostate cancer. But when symptoms develop, you may have trouble initiating urination. You may have a weakened urinary flow. You may feel difficulty in emptying your bladder. It may burn when you urinate. You may see blood in your urine or semen. In advanced cases, you may have pain in your bones. You may experience unusual weight loss. All these are potentially signs of prostate cancer, but they can be signs of other conditions as well. Now, you may be wondering about what tests you need to get, and I think I basically mentioned them. But there has been some debate about how useful the finger in the rectum or the digital rectal exam is in the examination for prostate cancer. I think that the digital rectal examination is a necessary part of a male exam because there are other conditions that can be discovered in the rectum, like rectal cancers, masses, abnormal hemorrhoidal veins, and things like that. So I personally believe that the combination of the digital rectal examination and the PSA are a necessary component of being checked. And when we do the digital rectal examination, we are checking for a nodule or irregularity in the texture of the prostate. Now, something new is a newer MRI technology that has been incorporated in our evaluation. More and more insurance companies are allowing us to perform the MRI of the prostate when a PSA is found to be abnormal. This this MRI technology functions very much like a mammogram in a female. It allows us to see within the prostate, and we found that there are certain appearances of cancer tissue that will heighten our interest in performing a biopsy. So if you happen to have an abnormal PSA and you're sent for an MRI of your prostate, there's a grading system that we use in deciding who needs to be biopsied and who we can follow. This is called a PIRAD score. The PIRAD score typically goes from 1 to 5. PIRAD scores of 1 to 3 can usually be followed with PSAs and determinations made on the need for biopsy based on the behavior of the PSA. But for PIRAD scores 4 and 5, these are indications that a biopsy should be immediately performed. The new technology allows us to overlay the image of the MRI with an ultrasound at the time of prostate biopsy, so we can accurately biopsy the spot that's seen on the MRI. I think I mentioned before that PSA is prostate-specific antigen, and basically it is a protein that's produced only by the prostate. It's not elevated by any other organ in the body. So when the PSA is elevated, it has nothing to do with you having a cold or any other condition. It is coming from your prostate. There are some recommendations that maybe you abstain from sex 1 or 2 days before having your PSA drawn, because it might cause an elevation. Or if you've had some type of urological procedure where an instrument may have been passed through the penis, this may elevate the PSA. But in general, PSA elevations are something to be concerned about. PSA can be elevated from infections of the prostate like prostatitis, but it's something that needs to be investigated further. Now, one other thing I'll add, the absolute number of the PSA is not as important as how fastly it rose over a period of 12 months. There are normal elevations of PSA just because your prostate is enlarging. So you will see incremental increases in PSA as you age. However, if your PSA increases over 0.75 over a period of 12 months, this is an indication that your level needs to be investigated further. Now, prostate cancer has been found to be prevalent in normal men who don't really have symptoms. Cancerous changes in the prostate happen. There was a famous autopsy study performed by a urologist in San Antonio, Texas, Dr. Ian Thompson. And what they found was that what they did was they looked at prostates in men who died from other causes, accidents, etc. And they found that at each decade, from 20s on up to 90s, that prostate cancer was present. It was just present at much lower levels and increased with age. And this means that not all prostate cancers are cancers that are going to kill the patient. So having a urologist that's knowledgeable about how to interpret PSA, you yourself being educated on what an elevated PSA means, can help you navigate through this process safely. So in 2018, there's a group with the government called the United States Preventative Services Task Force, which is tasked with determining if certain screening tests are appropriate or not. They made a poor decision and gave the PSA a D grade. And for a period of time, the publicity was that the PSA was not a useful test. And this was absolutely incorrect. The panel that made a decision on the PSA blood test did not have any urologists, nor did it have any oncologists who took care of prostate cancer. And for about 5 years, until the task force corrected its position, primary care physicians weren't drawing PSAs. So since that time, we've had an opportunity to evaluate the data. And as a result, there has been a significant jump in the numbers of advanced prostate cancer patients at initial presentation. PSA was developed in the 1990s. while it is not a perfect blood test, it remains one of the best screening tests for prostate cancer. Now, part of the process should include being educated about what an elevated PSA means, what a biopsy means, but being diagnosed or discovering to have prostate cancer should not be restricted. That is information that every person needs. And then it's your personal choice whether or not you want to be treated. Prior to PSA, most of the men that we saw with prostate cancer presented with a nodule and advanced prostate cancer, and the death rate was significantly higher in the era prior to PSA. So PSA has had a significant impact in reducing the number of deaths from advanced prostate cancer. So their decision to give this test a poor grade was based on several large studies that were performed in the European Union. And the unfortunate problem with that data is that there were no Black men. America has the population with the highest incidence and death rate from prostate cancer in the world. And this information should have been used in their decision-making process. Since PSA testing began, as I stated before, there has been a 66% reduction in the number of metastatic prostate cancer diagnoses at the time of initial presentation. Over the past 20 years, the age-adjusted prostate cancer mortality rate has decreased by 42%, which is excellent. What bothered me the most is in the period of the 90s, when I was an attending at Columbia University and also an attending at Harlem Hospital, Harlem being in the center of Manhattan, which is largely a Black and Hispanic community, the presentation of advanced prostate cancer was through the roof. And it took us years to change behavior and get the population in that community to begin to accept the concept of coming in for prostate exams, getting their PSAs checked, and we had a significant impact on reducing advanced prostate cancer. This decision was a major setback for those of us who work in high-risk communities. So as a Black urologist, who is at risk for prostate cancer, there is no such thing as overdiagnosing prostate cancer in a high-risk population that has the highest rate of death. Overtreatment may be an issue, but not overdiagnosis. Diagnosing the condition is how we save lives, and it provides patients the option of what to do. You know, at the time of diagnosis, you want to be found to have a cancer of any type at the earliest stage, so you have all treatment options on the table. There are situations where observation, not doing anything, may be appropriate, but you need to make the diagnosis, have this diagnosis made early enough so that these options are on the table. So there's been like an overstatement of risk and harm caused by prostate biopsies. The prostate biopsy process takes less than 10 minutes. It uses a small needle. It takes a small sample. The patient has an enema prior to the biopsy. You usually sedated so you don't feel anything, and it's ultrasound guided, and patients are given antibiotics before and after. And the risk of sepsis, which is bacteria entering the bloodstream, is less than 1%. So I believe in screening. And my organization, the R. Frank Jones Urological Society, has taken the position, which has not always been in agreement with the American Cancer Society, that Black men or men at risk should begin getting their prostates checked at the age of 40, along with a PSA blood test. I started getting PSA test in my 30s because of my family history. It's important to have a normal baseline test so you can understand when there's an elevation. So the sooner you get yourself examined at the age of 40 or close to 40, the better idea you will have of what your baseline PSA is. And it's very important that you know your family history. One thing that is culturally different about Black families is we do not discuss health information, let alone much information, and tend to keep secrets until things occur. So asking questions about your family's health history, about men in the past, what they may have had or may not have had, can help you understand your risk for having prostate cancer. So having the patient or you participate in the process is called, in a very, it's a formal way, informed decision-making process. But basically, it's just being involved in making your own decisions about your health. You should never go in a physician's office and leave all the choices and decisions up to him. So if you happen to have a elevated PSA and you need to have a biopsy, your biopsy will be performed. The tissue will be sent to a pathologist who will look at the biopsy under a microscope and determine if prostate cancer is present or not. And then depending on what the results are, this will lead to a discussion with your physician. So it's very important that should you be diagnosed with prostate cancer, that you understand all of your choices. And in the process of getting your biopsy, one of the most important things is the Gleason score. Gleason score is just a grade that the pathologist will give the cell type that he sees under the microscope. It's usually two numbers in a range of 1 to 5, and these numbers will be added together for your final score. The national average Gleason score is a 6. 8 through 10 is considered aggressive cancer. Gleason's 10s are the worst. Black men tend to lean more toward the 7s and 8s. So when you have prostate cancer, we go through a staging of the cancer. A common classification is the T&M classification, but for simplicity, I'm just going to use stage 1, meaning that you have a single spot that was discovered on biopsy. Stage 2, meaning that it's found in both aspects of the prostate, but it's not outside of the prostate. Stage 3 is when the cancer has grown locally outside of the prostate into tissue adjacent. And stage 4 is when it has spread to other organs like the bone. Bone and lymph nodes are typically the first places that prostate cancer spread to. In the old days, you might have heard of the diagnosis of a family member having bone cancer. That was more than likely a man with prostate cancer. So when the diagnosis is made, you want to sit down with your physician, and I would even say have a notebook and take notes. In the first visit with my patient, I have 2 books that I give them. One is a prostate cancer pamphlet produced by the National Cancer Institute. And then I have a book called The 100 Questions about Prostate Cancer. You should read and be as knowledgeable about this condition as if you were going to purchase a new car. And at your second meeting, you should have all of your questions listed so that you can ask all the appropriate questions. You may, a lot of people try to listen and not write things down, but getting the diagnosis of prostate cancer can be very shocking, and your memory won't be as good as you think. So it's good to write things down, take another family member with you so you can get as much of the information as possible. It's important that you not be afraid to get a second opinion. It's important that as treatment choices are offered, you ask questions about risk and benefits. And one thing you shouldn't do is get information from friends and other people who have had a particular treatment. They are not physicians. What's right for one person may not be right for you. So some questions that I would consider asking is, when the doctor does the biopsy, we typically take 12 samples. You might want to know how many of those samples had prostate cancer in them. What percent of each sample was involved in cancer? Was there evidence of extension outside of the prostate? What are the ways that the prostate cancer can be treated? If it's surgically removed, can I still get radiation if it comes back? Will I still have the chemo options or the hormone treatment? If you get radiation first, is it possible to have surgery if the cancer comes back? What is the chance of cure? We tend to look at I wouldn't say cure, but long-term disease-free survival based on 10 and 15-year increments. So what is my percentage of being cancer-free at 10 to 15 years after this particular treatment? How many of these procedures have you performed? What is your complication rate? What impact will it have on my erections? Will I leak urine? Can these complications be treated? These are all the questions I would ask. So this is a list of potential treatment options when you're diagnosed with prostate cancer. And all of the options are available when you are diagnosed early enough. So the most important part of this process is being diagnosed at the earliest stage possible. One option is active surveillance, meaning that you've been diagnosed with prostate cancer, but because of the stage and the particular level you're at a very low risk of progression, and you can be observed very closely. I have a whole cache of patients that I observe. This observation includes evaluating the patient every 3 to 6 months with PSAs, performing MRIs of the prostate annually, and if necessary, a prostate biopsy. While the MRI is great, I am still uncomfortable with allowing things with cancers that might grow and I can't tell. So the only way to know what's happening in the prostate is to perform a biopsy. The prostate can be removed. The surgical removal of the prostate has changed tremendously in the past 20 years. I perform all of my prostate surgeries robotically. It's basically laparoscopic surgery, takes a couple of hours. Patients at times can go home the same day, but at worst, they'll spend the night and go home the next day. There is no blood loss. The magnification is 8 times. Your ability to spare the nerves for erections is greatly improved when that approach is appropriate. And it's just a much better outcome for the patient with less pain. You have radiation therapy, which can be given in 2 forms. It can be the traditional external beam radiation therapy, and there are variations of this. I'm sure some of you have heard of the CyberKnife and proton beam radiation. These are all different modalities of delivering toxic radiation to the prostate. And you can also do what we call brachytherapy, which is the surgical implantation of tiny radioactive seeds, which I perform. These seeds are about the size of a grain of rice, and they're carefully implanted in the prostate under ultrasound guidance with the help of a radiation oncologist. And these things can be done in combination and incorporated with androgen deprivation therapy. So androgen deprivation just means that you are stopping the testosterone from reaching the prostate. The prostate cells grow in response to the active form of testosterone, which is dihydrotestosterone. Prostate cancer also feeds on testosterone. So we have medications that can stop the production of testosterone and temporarily shrink the size of the cancer and stop the growth. And this is a temporizing treatment, but it's part of a number of different treatment options that we use when trying to control prostate cancer, or in patients who may have a very, very large prostate and you're attempting to reduce the size of the prostate. Androgen deprivation therapy is part of that treatment. We do various types of hormone treatments for advanced prostate cancer. And these are patients that have cancer that has spread beyond the prostate, or the cancer has recurred after being previously treated. We can perform cryoablation. I can freeze the prostate to -60 degrees using these special probes. This treatment I use typically for patients who have had a cancer recurrence after radiation therapy. And then there's chemotherapy for very advanced prostate cancer cases. Gene therapy is being experimented with, and there are a host of new treatments being developed every year. So the horizon is great for prostate cancer, but what I presented to you are the primary options when you're initially diagnosed with prostate cancer. So active surveillance, this is a good choice if you're going to live, if you have a 10-year life, less than 10-year life expectancy, or you had a biopsy, you had a small percentage of, say, one core that was involved with prostate cancer, and your PSA is low. And when I say low, I mean less than 3. And you're going to be compliant with the follow-up, and you can be closely followed. There's no side effects from doing this. The key, though, is if that cancer starts growing, the trigger needs to be pulled on treatment. Regular biopsies may be required, which are inconvenient, but probably less bothersome than going through treatment. Robotic radical prostatectomy, I would say surgical options. I am a surgeon, so I do believe in surgery. In the appropriately chosen patient, surgery gives you about a 92 to 95% 15-year disease-free survival rate. Now, this all depends on the Gleason score, tumor volume, PSA, whether or not there was a perineural invasion on the biopsy or involvement of nerves, if there was invasion of the vasculature, and a host of other things that we use in making decisions. But surgery, in my hands, by far, in the right patient, gives you the best long-term disease-free survival. If there is a recurrence of the cancer based on a rise in PSA after surgery, the radiation option remains on the table, hormone option, chemotherapy option remains on the table. After your prostate is removed, your PSA essentially should be less than 0.01. Cons of the surgery are that in certain cases, if there's extensive cancer, you cannot perform a nerve-sparing procedure. So there may be problems with erection afterwards, which is treatable, and about a 5 to 9% chance of urinary incontinence, which is also treatable. A catheter is left in place after the prostate surgery because you are basically removing a section of the pipe and sewing the pipe back together, and the catheter diverts urine away from that while it is sealed, and that usually takes about 5 days. The Da Vinci robot is the system that we use for the robotic surgery. It's basically laparoscopic surgery. I still have to, at the bedside, place the laparoscopic surgery ports, but the robot is a system that you connect to the robotic arms. I have assistants with me, but it really allows you a certain level of dexterity that the human hands cannot perform. It allows you, with instruments the size of a pen, to reach places that you typically could not with hands. Is magnified 8 times. It is just a significantly better way of performing intra-abdominal surgery. Complication rates are less, patients don't bleed. It is the way to go for surgery. This is an image of the Da Vinci robotic system with the assistant by the table and patient, with the robot docked to the laparoscopic port, and the surgeon in the left corner at the control system performing the surgery. This is just a bunch of data just showing how significantly better the Da Vinci robot is over open surgery, which is how I removed prostates in the 80s and 90s. This is a picture of radioactive seed implant. It's done through the space between the scrotum and the anus in that flat area. We use ultrasound guidance and tiny needles to guide in the seeds, which are those small looking elements that you see on that image. And the beauty of the seeds is that it limits the amount of radiation that is delivered. It gives a radius of about 5 millimeters of radiation, so you can contain the radiation just to the prostate without exposing the surrounding tissues. The best outcomes often do require the addition of external beam radiation in combination. In the hands of a good radiation oncologist who has performed many of these procedures in the appropriately selected patient, you have a good chance at cure. The 10 to 15-year disease-free survival rate quoted with radiation by the radiation oncologist, which may be a little generous, but it's in the 90% range at 15 years. Again, appropriate selection will impact outcomes. You just can't do this in patients with bad high Gleason score, extensive cancer, and expect excellent outcomes. So being involved with your radiation oncologist, knowing your information about your biopsy can really help you make the appropriate choice. The risk to erections and the risk of urinary leakage is about the same. The only difference with radiation is that there is a risk of a chronic inflammation of the rectum and the bladder from radiation exposure, called radiation cystitis and radiation proctitis. The risk is 5%, which is low, but when it does happen, it is a problem. These are just some images of how they pre-model or pre-plan for placement of the seeds. The seed implants are not placed randomly. The radiation oncologist will take various images of your prostate using an MRI and an ultrasound to determine the size and shape of the prostate to make sure that they get the maximum coverage of the prostate with radiation. So after you've been treated, regardless of whether it was radiation or surgery, during the first year, I tend to check your PSA every 3 months. If your PSA remains stable, which after surgery should be less than 0.01, and after radiation therapy, it should be less than 2.5. The second year will go to every 4 months. If it remains stable, the next year you go to every 6 months. And then at some point you try to get to following a patient for once a year. So I'm hesitant to use the word cure because I have had patients who have been disease-free for 8 years, and out of the blue, PSA will start rising. So after you've had prostate cancer, you really need follow-up until you reach the ripe age of late 80s, because the prostate cancer can come back. And the only way you're going to know is getting your PSA checked and having somebody monitor you closely. This is a cryo machine. So the setup is similar to the radioactive seed implants. You put in the same position. We use the same template or grid to pass the needles through that area between the scrotum and the anus to place the probes precisely in the prostate. And then you use argon gas to freeze the prostate. We can get temperatures to as low as minus 60 degrees, and you typically will do 2 freeze cycles. And this is usually sufficient to kill the cancer. I do not recommend it as a initial treatment as somebody who is initially diagnosed with prostate cancer for the first time. I only use it for salvage treatment for patients who are having a recurrence of cancer after they've had radiation therapy. This shows how the needles are passed into the prostate and the ice ball is created. We put the needles in a alignment so that the entire prostate is covered, and you're actually able to shape the ice so it only freezes the prostate. We have a warmer in the urethra so the urethra is not damaged. And we have a thermometer between the rectum and the prostate to ensure that the rectum is not damaged. These are just some ultrasounds showing what the ice ball looks like as it forms. We monitor you extremely closely when we perform cryoablation. The CyberKnife is another type of radiation delivery system that is supposed to deliver radiation more precisely to the prostate, limiting exposure of surrounding organs and reducing the risk of injury to the bladder or rectum. So in a nutshell, this is kind of the Reader's Digest version of treatment options for prostate cancer. I think it's just very important as a patient and a client that you be as knowledgeable about any cancer that you're diagnosed with. When you sit down with the physician, you ask as many questions as possible. Do not be afraid to get a second opinion. No physician should be offended in somebody who decides they just want to make sure they're hearing the same thing twice. Involve your family in your decision-making process, because your outcome is going to impact everybody around you. Surgery has changed. It's a new day and age for surgery. The recoveries are better. Blood loss is less, nothing to be fearful of. And radiation treatment has evolved. The key is just understanding the type of cancer that you have in helping you make the right choices. Lately, there's been a big focus on genomic testing. What I can say about gene testing is that the BRCA1 and 2 genes that are associated with breast cancer have been associated with an increased risk of prostate cancer, particularly the BRCA2 gene, BRCA2 gene. So if that gene is in your family tree, maybe in the form of breast cancer, your risk of having prostate cancer is much higher than somebody who does not have that gene. And so you should get yourself screened as well as the other men in that family. There's also some new work showing that a gene that originated in West Africa that followed the Atlantic Passage during slavery is connected to prostate cancer. However, prostate cancer is not as the same prevalence in Caribbean men, Brazilian men, and African men as it is in African American men. So there is definitely some epigenetic factor. When I say epigenetic factor, I mean environmental things, dietary things that can turn on bad genes or turn off good genes. So there's something about the American environment that has made prostate cancer much worse in Black men here than in the rest of the world. And the only way we're going to understand this is through studies. One of my big pet peeves has been the lack of participation of African Americans in clinical research and medical research. And there's a lot of historic reasons why we don't participate, but there are a lot of good reasons of why we should. In prostate cancer, a lot of the treatment algorithms and decision-making tools that help advise patients on the best treatment and their outcomes is based totally on white men. And we know that prostate cancer is a totally different disease in African men. We just don't have the data to pinpoint the exact abnormalities. A Gleason 6 in a Black man is not the same as a Gleason 6 cancer in a white man. I'm part of a group called the Conduct Consortium, and we have put together a team of some of the brightest and best African-American urologists, oncologists, radiation oncologists across the board in prostate cancer. Our main office is housed at Clark Atlanta University, which is a historic Black college. And we are forging forward with something called the Conduct Prostate Cancer Registry Trial, which we hope will be the largest collection of data on Black men with prostate cancer so that we can drive the studies and get the answers that are needed to reduce the significant death rate from prostate cancer in Black men. So follow this group out of Arizona. We will be posting information on our 3rd annual symposium, which is coming up in September during Prostate Cancer Awareness Month. And my other organization is Clinical Diversity Solutions, which is another pet peeve of mine. African Americans are not represented in any of the clinical studies that are used to develop any of the therapeutics in the United States. These studies are conducted on overwhelmingly white patients. The information from the Human Genome Project has shown that there are significant differences between ethnic groups in what we call the cytochrome P450 pathway in the liver, where drugs are metabolized. Drug development goes through 4 phases. The first phase is one of the most critical phases. This is where the dose is determined and the side effect profile is determined. These phase 1s are typically all white patients, so that by the time a dose is determined, it comes to market without having been studied completely in Asians, Blacks, or Hispanics, or Native Americans. This means that the effectiveness of these drugs will always be in question. We have plenty, I'm sure you have examples in your family of patients who've been taking blood pressure medications, and yet their blood pressure is out of control. They still have strokes. They still have heart attacks on what is considered the standard dose of medication. This applies for all drug groups. So we really need to increase the participation of all cultural groups, especially high-risk populations in drug development, so that we get the same benefit as the majority. So on that note, I'm going to end it. I enjoyed sharing what I know and what I think about prostate cancer, and hopefully I'll get to talk to you again in the future.
Okay, thank you so much for everything. If you have any questions for Dr. Stone, please feel free to unmute your mic. If you have any issues, I can try to unmute the mic for you. Thank you.
Hi, Dr. Stone.
Hey, how are you?
Good. My name is Denitra. I really appreciated the information and education, so thank you. And my question just was about diet. What effect does diet have on prostate cancer, and are there certain things you can eat to help improve your chances of not
Yeah.
getting it, and vice versa?
So again, because of the lack of a lot of study, we don't really know the cause of prostate cancer. We know there's a link between obesity and increased risk of prostate cancer. There were some soft studies done in the 90s looking at lycopene, which is a enzyme in tomato products, on a study trying to understand why there was a difference, a decrease in prostate cancer in Italian men versus men in America. There's a decrease in prostate cancer in Japanese men, but when they migrate to America, the risk rises to the same as white men in America. So, there's some loose associations between diet, but nothing specific. So all I can say is eating healthy will reduce your risk of a lot of things. Being active, keeping your weight down, all those things can improve your chances against cancer.
Okay, thank you.
You're welcome.
All right, any other questions? Not at all.
Got a quiet group. They must be young.
We're not young. Or I'm not.
So one thing I will comment on, as I'm sure some of you probably heard precision medicine. So medicine is about to go through a radical shift where these big institutions are going to be incorporating your genetic material in creating treatment plans for you, which is a significant leap in treatment. But my fear, as always happens here in America, is that certain groups are going to be left out of this progress. So participating in clinical trials and being involved with the right groups and not being afraid of genetic testing with the appropriate group is going to be a part of how we move this forward. So they're building here in Birmingham, the University of Alabama is building a huge hospital that is going to be totally dedicated to precision medicine. So we really got to push this topic of being more involved in clinical research and not being afraid when it's conditions that adversely impact our community if we're going to benefit from the progress in medicine.
Okay. One more time for questions. Anybody? Okay. I have this.
Hello.
Yes.
Yeah.
Hi, my name is Albert. I work
Hi,
a lot
Albert.
with Renee, and I'm so happy to be part of this. It's so informative, and you did an amazing job. I guess my questions, I sent it in the Q&A portion, but I think I'll just say it out loud. What's your knowledge of, I guess, the sexual experience for men who've had their prostate removed and participate in anal receptive? I know you mentioned a little bit about erectile dysfunction and that coming back into play.
I can speak to it from the only change is that you're not having an ejaculation. I mean, we really don't damage the nerves for sensation or anything like that. It's more the nerves that are involved in triggering the erection. So patients who are experiencing erection problems, they may, depending on how bad, will respond to the oral medications. They may respond to injectables, and they also do well with the penile prosthesis if the others don't work. I haven't had any complaints about sensations or anything other than there is no, you'll have an orgasm, but there won't be an ejaculation because the prostate has been removed.
Okay, thank you.
Yep.
So when that has been removed, would those men need help with like, I don't know what you call it, like fertility or something like that?
No,
Like-
you're infertile after your prostate's removed.
Oh, well, that's disappointing.
Yeah, but usually prostate cancer is happening, 40s and above. So most individuals have already had children. I've had 1 or 2 cases of young guys in their 30s, and we'll do donate sperm at the sperm bank so they can be treated. And this is only if the prostate's removed surgically. After seed implants, I mean, you can still ejaculate.
Okay, yeah, that makes sense. Okay, well, I dropped a lot of information in the chat if you want to look up some of the stuff that Dr. Stone mentioned there, as well as his organization, Clinical Diversity Solutions, as well too. If you'd like to reach out to him personally, they are an official community partner with the Black Community Health and Wellness Association. And this entire nice webinar has been recorded and will be available on demand. So I will send it through email for the email that you guys put down. Through Eventbrite, and then I'll also upload it to our YouTube channel as well too. So that link will be available via our link tree. So if there are no other questions, I can go ahead and close the meeting. Thank you all so much for joining us
Thank you.
today.
Thanks for having me.
Yes, thank you. Bye.
Bye.